Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera to everyone. Thank you to the organizing committee for inviting me to give this lecture on precision medicine for non-communicable diseases using the genomics approach. So we know the concept for the meaning of precision medicine is to provide the right treatment for the right patient at the right time. And the aims of precision medicine includes providing or aiming to achieve earlier diagnosis, tailored treatment, and better classification of diseases. We also aim to sort of affect more effective prevention strategies. We also hope that precision medicine would allow the prediction of outcomes and also better disease monitoring. And of course, also to provide a value-based healthcare and better safety for our patients. There are two large initiatives of precision medicine using genomics that I wanted to share here. One is the 100,000 Genomes England, initiated in 2012, where it focused on cancers, rare diseases, and pathogens. It has been successful, and now they are going to move on to increase the numbers to 5 million individuals. The All of Us program in USA started in 2015, has the key precision medicine initiative there, and this will involve a cohort of 1 million individuals who will have their genome sequenced and have their data shared. And again, the focus here would be on non-communicable diseases. There have been a lot of large cohort studies and biobanks that have been set up and initiated, and these are key drivers for precision medicine. I showed here too the UK biobank that started in 2005 and has recruited 500,000 participants who have been well characterized and also sort of genotyped. Of course, we have our own the Malaysian Cohort project that has recruited 120,000 participants until now. So I just want to show an example how the UK Biobank has been leveraged and a lot of data has been obtained in relation to non-communicable diseases. So this slide shows the results from a GWAS study on coronary artery disease, where they discovered 15 new loci for identifying the risk for coronary artery disease. And this has been published in Nature Genetics. And for this, they investigated 120,000 individuals in a nested case control approach for the GWAS. And of course, this kind of data will be useful in a gene panel testing for risk assessment of those who are likely to get coronary artery disease. Okay, on our own local side, the Malaysian Cohort is also a key resource for precision medicine. It contains big data from baseline and also at follow-up. It also has biospecimens that have been collected, both blood and urine, biophysical measurements, and of course, one of the great strengths of the Malaysian Cohort is its multi-ethnicity in terms of the composition of the participants. And this is the snapshot of the biobank that sort of stores high-quality biospecimens from the 120,000 individuals. Now, I just want to show some of the examples of our own research in terms of sort of bringing, our research into the application of precision medicine. So this is a GWAS for type 2 diabetes study that has been done on 6,000 participants. As you can see, we leverage on the differences in prevalence of type 2 diabetes amongst Malays, Chinese, and Indians. The results of this have been published in 2015. So these are the SNPs, or rather the 7 genes or loci where they contain the variants that have increased the risk for type 2 diabetes in the Malaysian population. Majority of these genes are involved in the pathways influencing diabetes pathophysiology. We noted a smaller effect size compared to other population for these genes, but two of these genes, the FTO and MC4R, are known to increase the risk of obesity by up to 4 times in certain population. So next is the use of genomics to identify those with familial hypercholesterolemia. We know this is a common a condition, largely underdiagnosed. It is stated that about 1 in 200 to 300 people may be affected, and even commoner in some countries. And at this moment, only about 5% of FH patients that have been identified. So we embark on a whole exome sequencing studies to identify individual at risk. And of course, by having this information, we could avoid early coronary artery disease in these individuals. I'd like to share the results here. These are the causative variants in the Malay FH patients. As you can see, there are 3 tier genes that are involved, and we have discovered both known variants and also novel variants in our population. How can this be used is that we could actually screen for the presence of these variants and provide the proper intervention in terms of cholesterol lowering or also lifestyle intervention. Interestingly, we have also discovered protective variants in these patients, which means that if they have these variants, they are protected from having a high cholesterol and LDL level. So again, this is interesting, and this could be used in terms of prediction and also sort of giving them information as to their status and risk of developing coronary artery disease. So this is the next study that we've done. Another study that we've done. This is the use of a gene panel to predict the risk of sudden cardiac arrest. We actually analyzed 36 cases of from the Malaysian cohort that have died of sudden cardiac arrest. We analyzed using 174 gene panel, and we've detected causative variants in 12 of them. So this will be soon published. And I just want to highlight one of these cases amongst the 12 patients who have succumbed to sudden cardiac arrest. This is a 46-year-old male who was healthy at recruitment but died from sudden cardiac arrest at 47 years old. And our analysis showed that this patient had mutation in the KCNQ1, which is a cause for long QT syndrome and fatal arrhythmias. If had this patient been detected earlier with genetic analysis, he could have been treated with beta blockers and anti-arrhythmic agents. Okay, the next study that we've done is looking at diabetic kidney disease in type 2 diabetes patients. This is a nested case control study that involved 300 type 2 diabetes patients with kidney disease from stage 1 to 5, and comparing them with 300 type 2 diabetes patients that did not develop diabetic kidney disease since recruitment. We did genotyping on candidate genes and then analyze gene to gene and gene environment interaction, the results of which have been published last year. So what we have found is this combination of 1 genetic factor and 3 environmental factors that give an increasing effect size in terms of risk of developing diabetic kidney disease: age, sex, and BMI. And one particular marker you should remember from the previous slide of the sudden cardiac arrest. Again, this particular gene but a different variant that is causing an increase or risk of the type 2 diabetes patient developing diabetic kidney disease. Okay, I just want to move on to sort of a different area, which is pharmacogenetics. This is important because by doing a pharmacogenetic analysis, we could actually avoid adverse events and also optimizing the dose for individual patients. I show an example here of a 4 gene drug pairing or with possible interaction. The first one is the HLA-B1502 integritol, which is commonly used for treating epilepsy. The DPYD gene and 5-fluorouracil, a common anti-cancer drug, including for colorectal cancer. The CYP2C19 and the use of clopidogrel, or commonly known as Plavix, CYP2D6, and antipsychotics. It's so important for clinicians to realize the importance of doing or identifying these gene variants because of the risk of adverse events, as well as identifying the best dose of the drug for these patients. So I'd like to move on to cancer now. Precision oncology is also a hot topic now, and what we've done in our lab is to perform whole genome sequencing in 50 colorectal cancer patients, aiming to not only sort of achieve or find the or profile the mutations in our local patients, but also aiming to identify actionable mutations. You can see from this simple diagram, we can see the various mutations happening, occurring in each of these patients. And you can see that APC and TP53 mutations are similar in terms of frequency compared to other studies, whilst KRAS mutation showed a lower frequency than Caucasian patients. And in almost all patients, we found that they harbor at least one actionable mutation. So I want to show this particular CRC patient where there is a Duxi, this patient had a Duxi colorectal cancer in the rectosigmoid area and showed extensive genomic alteration. Even the Circos plot has, you can see, is full of structural variation and also mutation. And what we identified is as well possible targeted therapies in this patient, including the potential use of BRAF and EGFR inhibitors and inhibitors to PI3 kinase and mTOR. So again, this is another study that we did to identify a prediction panel for colorectal cancer for those in Dukes B and C, to see whether we could find a marker, to help clinicians decide whether to stop treatment after surgery or to give chemotherapy. As you can see, by using a microarray approach here, we separated the two groups, the low risk and high risk. And again, this would mean that we could use this particular 19 gene panel to identify patients who have low risk and would not require additional treatment after surgery. So there are also other potential applications of genomics in NCDs. The first one is refining disease classification in bipolar disorders and schizophrenia. Again, this is an untapped potential in Malaysia because we have a large pool of patients with bipolar and schizophrenia. We could apply the genomic association, genome-wide association studies to this. Next is identifying genetic variants for Alzheimer's disease. We know ApoE4 is the genotype, contains the genotype that would increase the risk of Alzheimer's disease. However, this is also an opportunity for us to look for and discover other genetic variants that could increase the risk for Alzheimer's disease. Thirdly, accurate diagnosis of rare diseases. Rare diseases, when combined, is actually not rare. It is quoted that 1 in 17 people, children and adults, may suffer from a rare disease. And using the application of either whole exome or whole genome sequencing, we could identify the causative mutation variant in up to 50% of these patients. Last but not least, another potential application is in autoimmune disorder. We could apply genomics or genotyping to identify genetic markers for autoimmune disorder, including those that would develop, complications from their autoimmune disease in terms of organ failures and so on. I'd like to sort of end by showing this national policy agenda for precision medicine. These are some of the key initiatives proposed by the Academy of Sciences Malaysia and the Ministry of Health Malaysia for 2021. Our plan is to submit this to the cabinet. These are the 6 initiatives proposed. One is to look at the relevant needs for regulation and acts, the setting of 100,000 genomes Malaysia, focusing on cancers, other non-communicable diseases, rare diseases and pathogens, setting up a national biobank where we would store high-quality biospecimens from different diseases that will allow access by different researchers to do a lot of discovery research and also correlating the genotypes with the phenotype. Talent management, precision medicine requires a lot of expertise in various fields, and we believe to prepare for or to go to further embark and consolidate the precision medicine initiative, we need to continue to develop talent for precision medicine. Laboratory accreditation is important for labs that are doing the molecular analysis, including the genomics analysis. Last but not least, the quadruple helix partnership that would involve the government, the academics, the industry, as well as the NGOs to ensure that all stakeholders are involved. So in conclusion, precision medicine would require a paradigm shift in healthcare. It also requires a multi-pronged scientific, clinical, and policy agenda. There's a need to collect large-scale data sets, including biological, radiological, and translational bioinformatics data. There's a need for big data and discovery research using high-quality biospecimens. There's a need to show the best of evidence, including in terms of value, of impact, and also cost effectiveness of the precision medicine approach. I mentioned capacity building in key disciplines, including computational techniques such as machine learning and artificial intelligence. And we believe, I certainly believe that the precision medicine initiative would improve healthcare outcomes of non-communicable diseases and be more cost-effective. And last but not least, the precision medicine initiative in non-communicable diseases will probably tip the balance towards a more preventive approach and also early detection of non-communicable diseases. I'd like to acknowledge our funders for our research and also our Malaysian Cohort project, the Ministry of Science, Technology and Innovation, and the Ministry of Higher Education, our University Kebangsaan Malaysia, my institute, the UKM Molecular Biology Institute, my collaborators and co-researchers, local and international, and the Malaysian Cohort staff. Thank you very much.